All right, should be streaming. I'll just pop over to Facebook to confirm. There we go. Streaming. All right, we are live. People are in the room. Let's not keep them waiting. Hello, everyone. Welcome back to Luncheon with the Experts, a Carcinoid Cancer Foundation and Neuroendocrine Cancer Foundation program. It is Thursday. That means it is time for the show. My name is Rain Bennett. I am your host this episode and every episode, and I'm a filmmaker and a writer by trade, but I've been working alongside CCF and now NCF for well over 10 years. It's 2025, I believe. 2011 is when we first met. So the years keep that time span keeps growing. I don't know how to stop it. But over that decade plus, we've created, I've lost count how many videos, but all different kinds of videos, live video series and Q&A sessions like the one you'll watch today, patient-centric documentaries, treatment-based videos, all kinds of videos, but all with one singular mission in mind, and that is to spread awareness and education about neuroendocrine tumors. That is what we're here to do. Now, this show specifically, if you're new to the show, new to this community, I want to say welcome, and I encourage you to reach out, introduce yourself, tell us where you're signing on from. I love to see how far the program reaches every week. You can see people starting to do that in the comment section as well. The value of this show, as I see, from my experience, and we've been doing this about 5 years now, is twofold. One, the information and hopefully answers to your question that you'll get from our guest presenter. And two, the shared stories and shared experiences from within the NET community. The support, the strength of this community is profound from my experience over the last decade plus. So I say that to say, I encourage you to embrace the community. They will embrace you back. A lot of the lessons learned, a lot of the paths forged come from those shared stories and shared experiences from other neuroendocrine patients, caregivers, support group leaders, etc. So welcome to the community. Let us know how you're doing and where you are, and hopefully we can start to build some of those connections. So today we are welcoming for the first time to the show Dr. Patrick McGarrah. Is it McGarrah, Dr.?
McGarrah, yeah, that's pretty much it.
Which one do you prefer?
I say McGarrah,
okay.
But I hear McGarrah enough, I start to wonder, is it McGarrah? I don't know.
No, today it's Dr. Patrick McGarrah. Dr. McGarrah, welcome to the show. For those that may not know you or the role that you fill in this community, tell us a little bit about yourself, where you work, who you work with, how long you've been working with neuroendocrine tumors.
Yeah, so I am a medical oncologist at Mayo Clinic in Rochester, Minnesota. I work closely with Dr. Thor Halfdannerson, who I'm sure is a familiar name and face to many on this call. So he's actually the one who got me into this world. And when I first was bitten by the NET bug back in 2017, I came to Mayo Clinic right out of med school that I had done in the Twin Cities in Minnesota. At that point, most med students, you've maybe heard a passing nugget about carcinoid tumors, carcinoid syndrome at some point. But really, you don't have much of a knowledge base. I knew I was interested in oncology, so I was reaching out to people to connect on research. Maybe I thought GI cancers would be interesting. And I was very lucky that after my multiple cold emails, Dr. Thor was one that responded back with enthusiasm and had a project on neuroendocrine carcinoma, poorly differentiated neuroendocrine carcinoma in 2017. And from there, the story unfolded, and I've stayed with it, completed my oncology training. Also at Mayo Clinic, I finished that in 2023, and then came on staff and lucky to join Dr. Thor and also Dr. Tim Hobday and working with neuroendocrine tumor patients.
Got it. Thank you so much. Appreciate you being here. Folks, a couple just rules of engagement before we move forward. You can go ahead and start sending in your questions now, just to guide you a little bit, and those of you who are regulars know what I'm about to say. It's very hard to handle and field very case specific questions in this format. So the best way to get your questions answered and hopefully get you further down that path is short, generic questions. If Dr. McGarrah needs a little bit more information or clarification, we'll ask for that. So short, little, generic bites are the best way for us to field these questions. However, there's no limit to how many questions you can ask. You can always ask follow-up questions as the show goes on. We try to get to as many of them as possible. Inevitably, we don't quite get there every week, but that's kind of what keeps the show going. We always have questions to answer. And if you do have a question that's urgent that we don't get to, one of the great programs that has come from the collaboration between CCF and NCF is the support line. And we'll try to put this link in the comments as well as any other resources that Dr. McGarrah mentions today. But you can reach that support line. This is anyone affected by NETs, patients, support group, caregivers, whomever, at ncf.net/support line. So again, if you have follow-up questions after today's episode, you can always reach out there and hopefully get some of those answers to your questions. So Dr. McGarrah, while we're waiting for some questions to come in, which are already starting, I just wanted to touch base on one thing. You mentioned neuroendocrine carcinoma before we started recording and just now when you were kind of giving your bio. Is that the primary percentage of your patients?
No, it's definitely not the primary. It has been kind of a specific academic focus of mine, these poorly differentiated high grade tumors. But just I think due to their sheer natural distribution, where the bulk of patients are going to be well differentiated, lower grade, certainly can't say that that's like the majority of my patients. So yeah, most of what I see in the NET clinic would fit into kind of what you think of as like, if there is a classic NET patient, but a lot of small bowel primary neuroendocrine lower grade, which comprises the majority.
You've touched on a few of the differences between the two. Can we back up a little bit and maybe for someone who's unfamiliar, explain the main difference between what we would call like a NET and neuroendocrine carcinoma?
Absolutely. And this is something that befuddles many oncology practitioners, frankly, even medical oncologists at academic centers. The nomenclature, the terms we use has changed a lot over the years. But the most current way we speak about this is that a neuroendocrine tumor with a T, NET with a T, is by definition implying that it is well differentiated. Well, what does that mean? That means that the cells of that tumor look somewhat close to what the original cell type that those cells were in the body physiologically in the small intestine. So the tumor cells, they're growing too much abnormally, but they look kind of like intestine cells. That means they're well differentiated. Contrast that with poorly differentiated. It simply means that when the pathologist looks at your biopsy under the microscope, the cells look very abnormal. The structures are highly distorted and different from a normally functioning intestinal cell, pancreas cell, whatever the primary site may be. And they're really two quite different diseases in terms of their natural history and how aggressively they behave. So NET is the well differentiated, and the poorly differentiated, we use the term NEC, neuroendocrine carcinoma. So C is the bad one, the more aggressive one. T is well differentiated, although we never try to pinhole ourselves too much into things like thinking well differentiated, benign. There used to be a lot of people using terms like benign carcinoid tumor, which I know we're trying to kind of distance ourselves from because it kind of minimizes some of the issues that patients have with this. So yeah, that's I think the most important distinction is knowing NET versus NEC, and then to get even more, not to get too bogged down in minutia, but the last thing I'll say about that is that the overarching term we are using now to encompass both of those is neuroendocrine neoplasia, so NEN, NENS. Now, I don't think any of this is going to displace the term NET because it's just kind of a nice term that's easy to say, so it's got good branding. But just to give a few kind of like minutia details to kind of make sure we're all on the same page of what we're talking about.
So NEN, and then it would kind of branch off to NET and NEC.
Exactly.
Yes, got
Exactly.
it.
And
Okay.
and yes, and people will use these incorrectly all the time. So always push your oncologist, anyone you're talking, your gastroenterologist, your surgeon, say, wait, you're saying NET, NEC, NEN. Which is it? Am I? If you're going to remember one thing, I would say it's to know, is it well differentiated or poorly differentiated? That is the key.
Awesome. Thank you so much for that. Questions. Oh, one question before we get going, because I see a few queued up. I know you're mostly in the GI area. Do you handle lung nets at all?
So I do,
Okay.
and this is one of these things where there's different turfs in medicine, and it's not nearly as clearly established as you might think. And different practices, different institutions will handle this differently.
Yeah.
And there's not necessarily a great rhyme or reason for it. Some of it's just historical, but the way, if someone comes in and a patient says, I want to get seen at Mayo Clinic, I have a bronchial neuroendocrine tumor, I would say maybe 60% of the time they end up getting fed to our thoracic cancers group, and the remainder end up coming to our NET clinic. So I do see lung neuroendocrine tumors as well.
Okay. So, and you're okay with those questions then today?
Yes, maybe not. Maybe I don't see quite as many, and wouldn't present myself as knowledgeable, but I think I know quite a bit, and I treat many patients with those.
Got it. Awesome. Thank you. All right. First question comes in from Heather. Have you ever seen a primary tumor be in the testicle? That's the case for my dad.
Yeah, I cannot say that I know of a specific case of a primary in the testicle. That is a new one to me. I've heard of a primary in the brain. I've heard of primary breast. I've heard of primary larynx. So we do know that neuroendocrine neoplasms and NETs, we see them in all parts of the body. In the testicle, no, I can't say I know a specific. It would certainly be a very rare presentation. And I think it would be important to do a thorough, full body PET scan to evaluate. Do we definitely think that's the primary? And you would definitely want to be involving a urologist in that type of a case to help with how to do any sort of surgery that might be indicated. But yeah, that is not one that I have heard of any of my colleagues that I can say, oh yeah, testicle net, I know about that. That's quite rare.
Yeah. Thanks, Heather. Let me know if you have any follow-up questions for that, and we'll try to get to those. Next question comes from Kathy. 6 months ago, I had a right lower lung lobectomy for 1.1 centimeter neuroendocrine carcinoid tumor at Mayo Rochester. My follow-up has consisted of a lung CT and pulmonology appointment. There's no reoccurrence in that lung, but a small solid nodule is now seen in the other lung. Very tiny yet. I question whether I should be seeing a NET specialist instead of a pulmonologist. What would your opinion be? Night sweat stopped when my lung lobe was removed, but has since returned. So similar symptoms. I'm being told rather, there's likely no correlation between carcinoid and the night sweats.
Okay.
So kind of what we were just talking about in terms of which team.
So I would say there's not a definite need. I would say like, oh, absolutely, you must have a medical oncologist if you're not going to be getting any sort of specific net medical therapy like monthly octreotide injections. That said, I think it would be important to be kind of following with someone who is at least familiar with neuroendocrine tumors. And I think if it is someone at Mayo Rochester, they're likely familiar enough or know how to get in touch with us. But at this point, the story that I hear, there's no clear evidence of recurrence. There is a nodule, which is extremely common in the entire population. And I would not necessarily presume or worry that is a recurrence, but I understand, and it because it takes kind of time. We have to follow it over time and see, is it growing, and does it merit us going back and doing another a resection or a biopsy? But just in and of itself, having a nodule is quite common, and many do not end up being tumor.
Got it. Thanks, Kathy. Hope that helps. Let us know if you have any other questions. Moving forward, Carrie says, do you know if neuroendocrine tumors secrete parathyroid hormones? My level has been elevated repeatedly, and my thyroid also faintly lights up on several gallium PET scans.
So I would say it's possible, but more likely that in that situation, it sounds like a parathyroid adenoma, which is a type of abnormal growth of an endocrine cell, but is not technically speaking a neuroendocrine tumor. So if you have a thyroid or parathyroid adenoma, that is definitely something that can exist and would be something that traditionally goes through an endocrinologist as opposed to a medical oncologist, and typically wouldn't be thought of as cancer per se. But it certainly is possible that a neuroendocrine tumor could secrete that, because we see neuroendocrine tumors secrete all sorts of bizarre things, and I'm sure it's been a topic on here before of the different hormones that can be secreted.
Absolutely. Next question from Dan. Dan says, have you seen lanreotide cause ALT/AST to elevate? Does this force, and if so, does this force a treatment change? I have a low grade 1 carcinoid tumor with metastases to the liver.
That is not on the list of side effects or common toxicities that I see with lanreotide. So if there's a really strong time relationship, cause and effect, like I had perfectly normal LFTs, then the only thing that changed is I started lanreotide. Certainly you have to entertain that, but it's by no means going to be, when you look at what are the common things to think about with starting lanreotide, liver enzyme elevation is not one of them. So I would be thinking very carefully about what other causes could there be. And there's a very wide range of things that can cause liver enzyme elevation, and a lot of it depends on what is the degree of the elevation, the timing, how long is it lasting, is it rising continually, what other medications are on board. But it wouldn't be at the top of my list, no.
Got it. Thank you. Thanks, Dan. Folks, if you just joined us or joined us a little bit late, this is Luncheon with the Experts, a CCF and NCF program. We're here today with Dr. Patrick McGarrah from Mayo Clinic in Rochester. And if someone is not here that you think should be, go ahead and tag them in the comments. Let them know the show is happening. Sometimes people forget. And also a special shout out to our growing community over there on YouTube. Love to see that those numbers grow every week. Let's keep it moving. Donna says, my oncologist and I are considering the ACTION clinical trial. Could you please talk about the possible side effects and risks, long-term and short-term, of alpha PRRT?
Yeah, good, great question. So ACTION is a randomized trial for patients who have had previous Lutathera, the current FDA-approved radioligand therapy, which is another situation where some background on the terminology is important. There's Lutathera, which is a brand name, and that is a type of PRRT. What is PRRT? That is peptide receptor radiotherapy. I think the simplest way when I explain to patients what I'm talking about with that is basically IV radiation. So instead of beams being shot from a machine across the room at your tumor, it is little drug particles being injected. It's basically radioactive octreotide or lanreotide. And so we call that peptide receptor radiotherapy. Another term we use is radioligand therapy. So just so it's not too confusing, because we switch terms all the time. So the ACTION one is looking at a promising new type of PRRT or radioligand therapy called alpha particle. And so it's just a different type of isotope, of radioactive isotope, that's attached to the lanreotide or octreotide molecule to deliver what we hope is a more effective, more powerful dose of radiation to the tumor. So the analogy I think of is Lutathera is basically your initial type of atom bomb. The alpha particle is your hydrogen bomb, an H bomb. Way more powerful, way more energy being delivered. Now, that said, we don't, the preliminary information we have so far is that it is not associated with really any increased toxicity. We have to always say that with a grain of salt because we don't have our full study readouts and long-term follow-up. But the preliminary information we have so far is that it does not seem to result in any different side effect profile beyond what you see with Lutathera. And so another thing to know about the Action 1 trial is that it's randomized. So the study is asking for patients who've progressed on Lutathera, is it better to try this new alpha particle treatment or to try one of the kind of standard options that's out there already, like doing a double dose octreotide or everolimus, otherwise known as Afinitor. And so if patients get assigned not to the alpha particle group, your oncologist has to choose one of the standard menu options. And for some patients, that's disappointing because everyone has a lot of enthusiasm about the new treatment option. But for this trial, they do fortunately have what's called crossover, so that if you get assigned on the standard of care arm and the treatment, you still have tumor growth, you then are eligible to still get the alpha particle therapy.
Got it. Thanks, Donna. Appreciate your question. From Sarah over on YouTube. Hey, Sarah. I have read that lanreotide can interfere with Lutathera if they are given at the same time. Is it important to give lanreotide 2+ days after a Lutathera injection?
Yep. Excellent question. And so this all comes from the fact that, the lanreotide or octreotide, and I use them fairly interchangeably. It's kind of like Pepsi versus Coke. They're both kind of the same type of drug. So lanreotide or octreotide are drugs that bind a receptor that's very highly expressed on neuroendocrine cells called the somatostatin receptor. So Lutathera is really, like I said earlier, is just octreotide type molecule with a radioactive particle attached. So they're both going after the exact same target. And so if they're both going after the same target, when they started developing this therapy, the worry was that, well, if you have these patients that are already taking octreotide, let's say for their hormone Flushing's diarrhea type syndrome, how is the radioactive drug going to even get delivered to the tumor if the receptor is already being occupied by the octreotide lanreotide? So for that reason, the protocols were all developed so that they want you to be off of your monthly injection for 28 days when you get a dose of Lutathera. And what they do is they say you get your dose of Lutathera, and this is how we do it at Mayo Clinic. You get your dose of Lutathera usually in the morning, and then in late afternoon, we give you your regular monthly injection. This is just historically how it's been done. There hasn't been, to my knowledge, any sort of testing. Is this really an issue? Would the Lutathera not work? But because it's felt to be easily accommodable or something you can accommodate in your schedule, that's how we have always done it. So that's the reason that they ask that you don't get your monthly injection right before your dose.
Got it. Thank you. And thank you, Sarah. Next question from Joy. Will using my far infrared sauna in my home cause my monthly lanreotide injection to come through my body too quickly? Is this safe to use? Is the question.
Wow. I have to say I don't have a scientific reason to think that would be an issue. I'm not aware of how the infrared lights would really be likely to penetrate deep into the tissues and inactivate the octreotide. That said, I don't think anyone's tested this. So my kind of gut reaction, my guess is that it's probably not an issue, but not knowing the details of exactly what is the wavelength of this light and everything else. So it's not a scenario I've encountered. Probably not an issue, but hard to give you a really firm, like, oh, I know we've tested this, because no one's tested it.
Yeah, fair. Thanks, Joy. Next question from Nancy. Wegovy medication says not to take it if you have MEN type neuroendocrine cancer. Would you caution against using Wegovy injections with any type of neuroendocrine cancer? I have been stable for over a year, but hepatic steatosis is progressing rapidly.
This is an excellent question, and one that I think is going to be coming up more and more because these Wegovy type medicines, or as Ozempic or GLP-1 agonists, they're a real kind of blockbuster class of medication for weight loss and diabetes, and they're quite effective for those. So I think we're only going to be hearing more about them. But for people who don't know, they on the warning label for these drugs is what's called a black box warning that says if you have a history of certain types of medullary thyroid cancer or pancreatic neuroendocrine tumor syndromes like MEN2 syndrome, they've shown in lab rats that when you give this medication, it can make the tumors grow. So there is a theoretical concern that these medications could somehow make certain types of cancers grow. I've talked about this with patients before and with Dr. Thor and other Mayo neuroendocrine folks. We think that overall, the benefits of the medications likely outweigh, and the medications meaning the GLP-1 agonists, the weight loss drugs, and especially if you're taking it for hepatic steatosis or fatty liver, likely outweigh the risk of theoretical tumor progression. So it's still something that's kind of, the jury's still out, and I don't think there's a huge, paper that we can point to that says, yeah, we've looked at this in detail, we know for certain there's no risk. But most of the practitioners who treat NETs that I know of are saying if there's a good reason to be on the GLP-1 drug, we don't let that stop us, with the only exception being if you actually have medullary thyroid cancer or actually have MEN2 syndrome, which is going to be a pretty small, probably no one on this call has either of those situations. Maybe I'm wrong, but not a common thing.
Got it. Thank you. A comment, not a question. Your patient Kent just wanted to say hello. Yours and Dr. Thor's patient.
Hello.
Signing on.
Thanks for joining.
Yeah, your reputation is bringing people to the show. I love it.
Excellent.
Next question from Ange. Ange says, I had a biopsy on a well-differentiated PNET in the head of my pancreas, and the biopsy results came back with no signs of dysplasia. The tumor has been present since 2018 with very little growth. I am scheduled for an octreotide scan next week. Question is, should I get the biopsy done again? Or what should be considered with that?
So, this situation sounds like, a small possible pancreas neuroendocrine tumor. These are something that's fairly common to encounter kind of incidentally, like you got a CT scan for another reason. Let's just say you're having abdominal pain or you were in a car accident and they did a scan for trauma. And so these coincidental small PNETs are often identified based on how they appear on the CT scan. And if they are able to be biopsied, I think it's worth doing, but often they're small enough that it's difficult to actually get a definitive diagnosis. In that situation, I often, if it's a very small tumor, I think it's okay to usually observe these with serial scans just to see if it's growing at all, because oftentimes these are not going to grow at all over the period of even many years. So small pancreas neuroendocrine tumors, no evidence of metastasis. It's nice to have a tissue diagnosis for sure, but if you haven't got one, I wouldn't say that you necessarily have to. I would advise all patients to keep going in for biopsies if there's no evidence that it's growing.
Got it. Thank you, Ange. And speaking of our friend Kent, Kent says, I'm currently 3 infusions into the alpha-PRRT trial. Assuming everything is stable with tumor growth, etc., what are the typical next steps? What might they be after the 4th infusion?
So typically after, and there's no typical with alpha particle, I suppose, because it's so new, but The way I think it's going to work is everyone's going to be on observation at that point, and the hope is that it will allow you to be in kind of a treatment-free period for a good chunk of time. Now, if you take monthly injections for a hormone production syndrome, carcinoid syndrome, that would be a different reason to stay on a therapy. But if the treatment works how we hope that it would work, you would just be on observation. So you'd just be getting kind of regular scans to see how things look.
Robin says, are more oncology clinics treating NEC, neuroendocrine carcinoma, in reference to our earlier conversation?
So I would say any neuroendocrine focused person definitely is going to see neuroendocrine carcinoma. I'm not sure if the question is getting at, is it becoming more common, or just would it still be appropriate for any oncologist? I think it would be.
Yeah.
Any oncologist, if they see general oncology patients, that should be a type of patient that they would see.
What about the part of it perhaps being more common? Do you feel like that's the case?
So I don't know that I can say neuroendocrine carcinoma itself is becoming more common. I know neuroendocrine kind of writ large, NEN, is definitely rising in incidence. But I don't necessarily think I have reason to say, oh, there's more NECs that we're seeing.
Fair enough. Thanks, Robin. Let me know if you have another question. Moving on to Heather. This is actually a follow-up on the potential primary in the testicle question we had earlier in the show regarding that. I think this was about her dad. He had a dotatate PET scan, and there was some activity on a few abdominal lymph nodes. We're waiting to see if they think it's operable. He has 0 symptoms right now, but he was hospitalized with swollen lymph nodes, which led to this diagnosis in February. So antibiotics and steroids stop the pain, and there's not really a question, but she says it's just all really confusing. So just adding a little bit of context to that conversation, because remember we had said, haven't really heard of a primary being there, doesn't mean it's not possible.
Yeah, and I'd be wondering, was there an actual tissue biopsy of the testicle? The testicle is not often an area that's biopsied. Usually what they do is they actually just remove an entire testicle. The reason being that in kind of your usual testicular cancers, they worry that if you just stick a needle and biopsy, that it actually spreads the tumor out. It's one of the rare situations where you do actually worry about a biopsy spreading cancer cells. So I think number one is to know, has this been confirmed with tissue, or are they basing it on there being a positive PET scan? So would need more detail to understand exactly what's going on there.
Yeah, great questions, Heather. Let us know if you have any more information on that, and we'll try to get to it. From Bridget, who is a patient of Dr. Thor. Hi, my brother and I had matching tailbone tumors and removal. We had Curriano syndrome. I'm not familiar with that. Is that Curriano? Does she mean cushions? No, I don't know. I'm not sure. Anyways, it says we had Curriano syndrome turn net. Have you seen any cases? Curriano. Okay, no, that is
There's stumping me. I'm having
a rare genetic.
to Google something.
So
here.
am I. So am I. Sorry.
Yeah.
We'll get there, Bridget. Caused by MNX1 gene.
Let me see. Huh. Oh, so it looks like, it leads to abnormalities in kind of those tailbone region, and there's probably genetic alterations clearly in that area, which can lead to abnormal cell growth and for the cells to start kind of transforming and looking like different things. And so it sounds like in this case the cells started producing neuroendocrine tumor markers. That's how when they do a biopsy, they decide, okay, we see abnormal cells on the scan. When we biopsy it, how do we decide that that's a neuroendocrine tumor? And the way they do that is that the pathologist adds dyes to the tissue, in particular a special dye called chromogranin, and then another one called synaptophysin, different than the chromogranin level in the blood. Just throw that out there. This is just a protein that neuroendocrine tumors make. So if the dye is expressed in the tumor cells, then they say, okay, these cells are neuroendocrine tumor cells. So that must be what happened with this kind of sacral agenesis syndrome, which is what I'm learning now is Currarino syndrome.
There you
Or
go.
Currarino syndrome.
Well, thanks for the question, Bridget. Oh yeah, Currarino syndrome. I see that.
Yeah, we
Bridget,
both heard something.
we sure
Yeah,
did. Thanks, Bridget,
yeah.
and hope that helped a little bit, Bridget. If not, or if you have follow up questions, please let us know. We're still here for a little more than 20 minutes. This is a big question and probably very case specific, but we can talk about the general things to consider. Lori says 7 years ago I had a 9 millimeter net in my lung. It was taken out. 7 years later, I'm stage 4 with nets all over my body, including my bones. The question is, what happened? And obviously, that's a very big and kind of vague question, but I think it gives us an opportunity to talk about the things that can happen with this disease.
Yeah. Yeah, so obviously with the disclaimer of there's probably a lot of details we'd have to know, but the most likely thing, assuming that it is the same net that was seen in the lung, the same tumor cell, is that when they removed that tumor in the lung, there was more there that wasn't seen on scans or even in the surgery itself when the surgeon was looking around the thoracic cavity. So there were tumor cells that were probably spread into a lymph node. And over time, they spread throughout the body. I don't know what kind of imaging surveillance was done, but the tumor, there was probably tumor cells left over after the surgery, which happens a lot. It's hard to know what was done, if it was done kind of the right way, the wrong way, can't say. But it is not at all, even when you do everything perfectly, we see this happen where we think we got it all and the tumor cells are hiding in a lymph node or some other space, and then years, in the case of neuroendocrine tumor, it'll be years later because a lot of these grow very slowly.
Got it. Appreciate that. Thanks, Lori. Sorry to hear that. Let me know if you have any other questions. I've had a couple of people ask about dip neck, and the questions are very general in terms of is there anything new with dip neck? So I'll just toss that.
Yeah. This is somewhat of like something we're hearing about more. It's a newcomer, so for people who don't know, I'm going to make sure I get all the acronym correct. But it's basically a type of a lung neuroendocrine tumor, but it's this diffuse intrapulmonary neuroendocrine cell hyperplasia. So as opposed to there being kind of a big, chunk of a tumor, like having a softball in your lung, it's having a lot of abnormal growth of neuroendocrine cells in the lungs. Because remember, neuroendocrine cells are normal cells. Everyone has neuroendocrine cells. If those cells grow too much, we call it hyperplasia. And hyperplasia is simply on a spectrum of calling something a little bit of abnormal growth on the low end versus on the most extreme end, you're talking full on cancer. There's everything in between, and hyperplasia just means some of these neuroendocrine cells are growing too much. But because they're neuroendocrine, they kind of have fallen into the realm of things we talk about and see in our neuroendocrine tumor clinics. And what these can cause seems to be almost kind of like an asthma syndrome with a lot of coughing, wheezing, respiratory syndromes. So often these patients we will follow with our pulmonologists. The best treatment for these is not well known. There's some limited data that using monthly octreotide type injections can sometimes help and improve symptoms, but we aren't yet at the place where we know that if you have a dip neck diagnosis, you should go down the same treatment path and get Lutathera and Afinitor and all these things. That's not yet done. So it's kind of a newer thing. It's not, we don't quite know where to put it on our treatment spectrum, but it's often followed with a pulmonologist and with a neuroendocrine medical oncologist.
Got it. Thank you. And thanks for your question. Folks, we got 20 minutes on the dot. Let's keep moving forward. Hello, Ursula, with the next question, our friend from South Africa. Had my 9th round of nuclear treatment, PRRT, 2 weeks later, and my ALT went up from 700 to 1500. The question is this normal? I think we had a similar question earlier.
And so this one, a ninth round would be, in the U.S. we're probably have less experience with PRT than other places, especially. Actually, I don't know if it's any connection being South Africa to actually the Dutch. And that's in Rotterdam. That's where actually a lot of the original PRT studies were done, but it's not something we've done going up to 9 treatments here. So I don't have as much personal clinical experience doing that. That those numbers are pretty high if it's on the same scale that I'm used to. It all depends on the units, but an ALT that's over 1,000 is quite serious and needs to be evaluated promptly. And anyone who I treated with PRT who is getting liver numbers in that range, we would have to be kind of really following things closely and trying to figure out what's going on.
Well, thanks, Ursula. Let me know if you have any other questions. Good to see your name. From Jordan, is double dose octreotide given if you have progression on single dose?
Yeah, the answer is yes. It is considered, an acceptable treatment option. It's obviously very easy or low stakes, and that there's not really, new side effects to be worried about typically. And it's a drug that you've already been on and have presumably been tolerating it well. I don't know that we think of it as, a particularly highly effective thing. So it's not something I'm doing all the time. But if someone's not in need of kind of a really, our best treatments necessarily, and they kind of want to try something that's not much additional investment in toxicity or time, I think it's a reasonable thing to try.
Okay, sitting question. From Joy, will injections of lanreotide over a period of time cause pancreatic inefficiency? What would be the length, and what would be that length of time? Will the pancreas return to normal function if the injections are stopped?
Yeah, so that's an excellent question, and I think important for people to be aware of. So these monthly injections, octreotide or lanreotide, are drugs that are trying to mimic a natural hormone we have called somatostatin, which is a hormone that the body produces to regulate our digestion. But the term statin means stop. So it's the natural hormone purpose is to kind of slow down digestion. And part of digestion is secreting pancreas enzymes. So as a byproduct of these injections, it tells neuroendocrine tumors to slow down, but it also tells your normal digestive cells, like your pancreas, to stop secreting enzymes. So some patients do find out that they get diarrhea in the first few days after these injections, which is always disappointing because some people are taking these injections for the whole purpose of improving diarrhea. Well, this is a different type of way to get diarrhea that's unrelated to carcinoid syndrome diarrhea, but is really a side effect of the injections. And it's caused by the fact that you don't have as much pancreas digestive enzyme, which results in kind of fats getting into the colon, which the end result is diarrhea, often oily. So if you see oil, they call it steatorrhea. So oily stools would be a classic for pancreas enzyme insufficiency. To answer the question, typically this is something I would think of that's reversible if you were to stop the injection, but often patients who are getting this need the injections. And so there's a way to try and offset that, and that is to take Creon, which is the brand name of pancreas enzyme replacements. It's an actual prescription medicine of pancreas enzymes, and this is important, especially for patients who've had, for example, a full-on pancreas resection. They don't even have a pancreas. They have no enzyme. So this is their only source of pancreas enzyme. So there's a way to have patients take these enzymes sometimes just for the first few days after the injection to help with some of that pancreas enzyme insufficiency.
Got it. Thank you. We've talked a lot about alpha PRRT today. Jim has a question. Is alpha PRRT only in trials at some locations, or is it insurance approved, and how widely available is it?
So it is only in trials, at least I know for sure in the U.S. And I think that's probably mostly true elsewhere in the world. That it's still relatively new, at least when we're talking about some of the newer alpha particle therapies. Now, technically speaking, there's some prostate cancer treatments that count as alpha particle, but really what we're talking about is the actinium dotatate drugs, which is what Action 1 is, lead 212, which is another alpha particle. Those two drugs are only on clinical trials, and that's the only way to get them at this time. But hopefully the trials will show benefit to patients and will get them approved and much more readily available.
Got it. Thanks, Jim. Good to see you. From Heather, can a grade 1 turn into a higher grade?
The answer is yes. And when we talk about grade, which we haven't covered yet today, so we've talked about differentiation, which is just, does the tumor cell look kind of like a normal cell, or does it look completely bizarre? And that's how you delineate between well-differentiated and poorly differentiated. That is different from grade, which is really a measure of what % of those cells are actively dividing and growing. And they do that with something called a Ki-67, which many of you have probably encountered in your pathology reports reviewing your clinical notes. That is simply the name of a protein that marks cells dividing. So when they look at your biopsy, they look at how many of the cells actually are showing this protein, Ki-67, which means they're dividing. In a lot of patients, it's only 1%. 1% of cells at that moment are actively dividing, and that means that it is a grade 1, a low grade. If more than 20% are growing, then it gets called a grade 3, because at that moment in that tissue, 20% are growing, or whatever the number is. We have found very often that patients may, when they're initially diagnosed, they have a small bowel tumor, that's the only place they have it. It gets resected. They call it grade 1. It was 1% Ki-67. That if they then unfortunately have a recurrence, so let's say 2 years later in the liver, and they sample those cells, lo and behold, when they sample these, it turns out now it's a grade 2. The Ki-67 is 14%. So we see that all the time, and it seems to be common, especially when you're talking about a tumor that's metastasized further from the primary site. And so the grade is not something that's fixed in time. It can definitely change, whether it's that the tumor cells themselves are changing or that it's a different kind of population of cells is the one that managed to escape and get to the liver. We don't know. There is, though, on the other hand, simply issues where you could just have different sampling of tumor. If you've got a big tumor and you stick a needle in it, well, that doesn't represent every cell in the tumor. You're only looking at a tiny fraction. And so if by just random chance, the cells where that biopsy were taken are only cells growing where only 2% of them are growing, you're going to end up reporting that as a low-grade tumor, whereas there might have been 1 inch to the right of that cells that were growing that weren't biopsied that were growing at a much higher rate. So we talk about this grade like it's a fixed thing and like it's absolute, but there's a whole lot more nuance to it, and it can frankly be confusing and complicated for us as well.
Got it. Thank you. Folks, we have 10 minutes left. We're going to keep trying to get to as many as possible. A lot about PRRT today. Eltaz says, I had 4 rounds of PRRT. Now, after 6 months, my hemoglobin and platelets are declining. What do you suspect?
So blood count changes are one of the definite kind of on the list of side effects from PRRT, because when this drug is given, you are exposing the bone marrow to some levels of radiation. A lot of times the lower numbers can be kind of temporary, like you see it for just a period after each dose, and then they come back to where they were before the next dose. But there's also a population of patients where the counts seem to be low for quite a while afterward, even many months or even years. And then the most kind of serious complication is when not only are the counts low, but they're so low that we end up doing more evaluation and workup and see that there's actually genetic changes in the bone marrow, and you have what's called a myelodysplastic syndrome, or even something that can resemble a leukemia. So that's kind of the most feared side effect of PRRT Lutathera treatments, is getting an irreversible bone marrow damage that can even turn into a leukemia. Now, just because, to answer the question, the counts are low doesn't mean that's what you have. But if they are severely low, like almost to the level where you need a transfusion, this does require attention. And so I would definitely be looking into this, following it. Is it getting lower and lower, or is it just a very mild decrease? But if it's a substantial drop, then really you need to be evaluating, has there been a more serious damage to the bone marrow, and that would require being seen by a hematologist, like a blood doctor.
Got it. Thank you, and thanks for your question, Altaz. Ruby says, I was diagnosed with medullary sponge kidneys when I was 8, and over the years I've had multiple infections. The question is, could this cause a problem with my nets?
Interesting. So I'm not aware of how having infections in and of itself would, cause nets. So I'm assuming there's kind of two separate problems, or, the born with the medullary sponge kidneys, and then separate issue have neuroendocrine tumors. I don't have a reason to see why infection necessarily would be a problem that makes the neuroendocrine tumor issue worse. I mean, obviously having the more active medical problems you have, there's certainly ways that can make it more difficult to treat when you have multiple things going on, but there isn't any sort of specific connection or issue where I say someone who's having recurrent infections, in particular from, I assume these are maybe some kind of urinary tract infections, or even like upper kidney infection. We call it pyelonephritis. There's not a specific tie-in to that making neuroendocrine tumors worse that I'm aware of. I hope that answers what you're getting at.
Hope so. From Sue says, 4 years ago I had a PNET removed by Whipple. I had a gallium-68 dotatate PET scan in April, showed a 1 centimeter lesion on the liver with multifocal lesions, followed by an MRI, and was told they didn't see anything on the liver. I was told it wasn't cancer. The question is, can a NET still exist, and what follow-up testing would you suggest at this point?
So, so it sounds like there was a PET that showed a lesion on the liver, but then the MRI did not show a lesion. Am I understanding it, Rain?
Correct.
Right? So in that situation, if it's at all possible, I would entertain getting a biopsy, especially if there isn't any other known active neuroendocrine tumor present. If presumably you were disease-free and there's a concern for a lesion, and it was showing brightness on the PET dotatate, I would definitely consider whether that should be biopsied. There are situations where we think there's something in the liver and the MRI gives information that a really experienced radiologist can say, okay, yeah, I see what you're talking about, but it's actually showing features of a benign liver abnormality, such as a hemangioma is a common one, or cysts happen in the liver. So a lot of people have random stuff in the liver that at first glance sometimes gets called out like it could be a tumor. So that is something that can happen. And the only way to really definitively settle that is with a tissue biopsy.
Got it. From Matt, Matt says, I finished my 4th PRRT treatment recently in March. Feeling great for the most part. Labs look better in regards to markers. Question, I would swear my testosterone levels are up. Could that be a positive result of having serotonin levels dropping?
So sorry, as the testosterone levels have dropped, or they're up?
No, he says, I would swear my testosterone levels are up. So something is indicating that, and his question was, could that be a positive result of having serotonin levels drop?
Interesting question.
Yeah, I
Yeah,
thought
I
so.
not to my knowledge. Testosterone is primarily, it's produced by the the testicles, in response to hormones that are produced in the pituitary. Um, if anything, actually, the pituitary has some low level of somatostatin receptor or dotatate uptake. So if anything, you might even think that Lutathera would cause maybe even some damage to the pituitary and lower testosterone. So I can't come up with an explanation for how that would be the case. I don't know if you've actually measured the testosterone levels and they're up. It's a pretty difficult thing to just kind of feel testosterone level up. I mean, maybe you feel more sex drive, more body hair. These are the common things with testosterone, but the testosterone levels fluctuate quite a bit, depends on the time of day. So no, that wouldn't be something I can say I've heard of happening, and it would be hard to give you an explanation for why serotonin levels would be related to that
Yeah.
different pathways.
Got it. Thanks. And thanks for your question, Matt. First time I had heard that too, so I figured we'd take a stab at it. Next question comes from Dan. I received a tandem treatment of PRT in Germany using lutetium 177 and PB 212 or
Mm-hmm.
212, which I'm not
And
familiar
that's
with what
lead,
that is.
that's alpha
Have
particle. Yep. Yep. Lead 212.
Okay,
Yeah.
okay, got it.
Yep.
Oh, that's right. That's yes, yes, yes. Have or is there any research in the U.S. for this type of treatment as of yet? Partial remission was
Yeah.
achieved.
No, that's fantastic. No, to my knowledge, we don't have any tandem, combining both with, the Lutathera is beta emission PRT. So I'm not aware of any active studies that are using both, but I think it makes sense to consider that because there's some pros and cons to each type of radiation. One of them, I said it's like an H bomb. But it's actually only hits a smaller, precise area, whereas there's no margin of error. Where sometimes there's tumor cells that might be beyond where the actual apparent target is. So there's some theoretical pros and cons to both beta and alpha. So I can certainly see why it's something that should be explored in clinical trials. Again, in Europe, especially the Low Countries, they're a little further along or have done more, not necessarily always on clinical trials. So they're doing things that we aren't doing yet in the United States. Whether we think they will be
Hmm.
worthwhile or not is also not totally clear. But I think it's something worthy of study.
Got it. Thank you. And great question, Dan. Probably last one. I want to get to this one from Kevin over on YouTube. I have 2 non functioning nets in my upper chest, and they are starting to restrict my trachea and breathing. They are in a place that has been deemed inoperable. So the question is, are there any new treatment options that I could consider? I'm currently on Captem right now, and it seems to be stopping and even moderately shrinking these tumors to give me breathing relief. Any other thoughts for Kevin?
Yeah, I don't know if radiation has been done, but I would definitely be considering radiation for that. Treating it with medical therapy, meaning drugs like Captem. I would also put Lutathera or PRRT in that category. Using the standard kind of menu of options for NET would be part of this. But when you're talking about anything threatening the airway and breathing, that's obviously quite serious. And that's where you really would be kind of pushing your thoracic surgeon, depending on where in the trachea, to really say, is this truly inoperable? There's nothing that can be done. So I would strongly advise making sure you've been seen by a tertiary, meaning a very big hospital, academic hospital center with thoracic surgeons that can do things that not all thoracic surgeons can do. So I would really push that question as to, is this truly not resectable? I would explore radiation, and sometimes there's even other interventions like stents, because that's obviously airway is critical. So we really would kind of really do quite a lot to try to mitigate that situation beyond just medicines.
Well, folks, Dr. McGarrah, you landed the plane right at the top of the hour. So that is our show today. I want to just say that Melissa says, thank you so much for such clear explanations. That's you, my friend, and for breaking down terms used. So I'm really glad we took the time and you kind of laid some groundwork and some foundation for a lot of those. Dr.
Yeah.
McGarrah, thanks so much for
My
being here for your
pleasure.
first
Yeah,
time on
thanks
Luncheon
for
with the
having me, and really, really great questions from all the audience, patients, families, everyone. Really
Absolutely.
impressed, and great to see such enthusiasm from all the community here.
They bring
Yeah.
it every episode. And folks, I see we had a lot of questions we couldn't get to today. I'm sorry for that, but we will be back in a couple of weeks and hopefully get the answers to some of those questions. I'll reiterate, like I did at the beginning of the program, reach out to ncf.net/support line if there's something that just cannot wait to the next episode. We want to try to get you the help that you need. That is what we are here to do. But I appreciate you as always, and I hope this program today helped answer some of your questions. Finally, my name is Rain Bennett. I have been your host. Thank you for watching, and please join us next time on Luncheon with the Experts. Stay healthy, stay